Yes, doktor. Hello?
Kenapa tak ada suara ni? Assalamualaikum.
We can hear you, doctor.
Okay.
Can you hear us now? Can you hear us now, doctor?
Zulfarhan, can you answer me? Can you respond to me? Boleh?
Hello? Hello? Hello?
Dah ada ya? Saya tak dengar ni. Tak apalah, I will leave and out and in again lah. Assalamualaikum.
Waalaikumsalam.
Zulfarhan, boleh?
Doktor dengar?
Ada my microphone error ni. Dengan speaker kok.
Hello?
Microphone okay, speaker ni error ni. Assalamualaikum.
Salam?
Hello.
Hello?
Dah tak buka. Tak bisa.
Hello?
Tak ada. Assalamualaikum. Masih tak boleh dengar eh? Saya, tak ada suara nanti.
Waalaikumsalam. Hello.
Assalamualaikum.
Salam.
Okay.
Hello. Salam.
So, tukar handphone lah sekarang. Alright. Allah SWT kitab Al-Fatihah. Okay, who will present first?
Me, doctor.
Ain.
Yes.
Okay. Yang yesterday, yang Selasa tu siapa tadi yang dah lupa Sasha. Dan siapa lagi?
Shasha, Aisyah,
Okay.
Puteri, Siti Aisyah.
Alright. So, 5 lagi kan? Alright.
Ah.
So, what's your topic?
I'll be talking about OGT and MGT.
Okay. Alright. So, you may start.
Okay. Can everyone see my slides?
Okay.
Yes.
Okay.
Yes.
Okay. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Noah Ainadia, and I'll be talking about the orogastric tube and the nasogastric tube. So, this will be my contents for today. Okay, so what is the orogastric tube or nasogastric tube? So, they are basically hollow tubes that are placed either through the nose or the mouth into the throat and end at the tip of the stomach. Okay. So what are the difference between the tubes is, so orogastric is you put it through your mouth, and nasogastric, the tubes that are placed through the nose. And also orogastric are usually used more in neonates, especially because they are obligatory nose breathers, and they are also preferred in small infants since it prevents airway blockage. Okay, and also conditions that it can be used or it needs to be placed are for older children in comatose, intubated or unconscious patients. Meanwhile, for nasogastric, that are usually put through the nose, it should be used preferentially, especially if the patient is still alert or semi-conscious. And also, if you can see, okay. And for orogastric tube, it's usually for older patient, for comatose, because as you know, in older patients, they sometimes can just pull it around or even bite the tube. So that's why we usually use nasogastric tube if the patient is still alert. Okay. Next, what are indications for this tube? So first of all, is for nutrition or feeding administration. So for example, for enteral feeding, it's especially used in the premature infants because some of them have poor oral intake. They also have poor appetite, or even in critical illness such as cerebral palsy, where they have poor pharyngeal control. So it's difficult for them to swallow, right? Okay, next is for medication administration. It usually provides a safe access route into the GI tract for the medication administration. And next, for the evacuation of the stomach content. So, for example, we can remove the air or even drain the stomach content, for example, during bowel obstruction and such. So what are the contraindications of this tube is during the post-operative period. So for if we insert back the tube into any recent surgery to the mouth, pharynx, or esophagus or stomach, it can irritate that surgical spot. And then next, any known structural abnormalities such as cranial atresia, any suspected spinal injury, any clinical disorders of the esophagus or stomach, such as esophageal varices, esophageal stricture, and then any suspected nasal, maxillary, or oropharyngeal or esophageal trauma, because it can aggravate the injury more. So, and then next is this any suspected base of skull fractures or even any bleeding disorder, because we have to be cautious since there's a high risk of bleeding. Okay. Next, what are the equipments needed? So we can have PPE such as gloves, we can have the cubes, we can have lubricant or sterile water, we can have the oral syringe, or we can have a permanent marker, non-toxic permanent marker or tape. We can also have a suction, pH strips, and also skin protectant. And optionals are a pacifier, a cup of water, or even a blanket and straw. So I'll explain why it's optional. Okay, so for the tubes, there are different sizes of tubes, and it's based on the size of the patient or even the age. So for example, for premature neonates under 2 kilograms, we use the size 6, and then for newborn, same as 6. And then for infants, toddlers, and preschoolers, basically up to 5 years old, we can either use the 8 or 10. And then for the school age child, so it's between 5 to 12, we can also use the 10. And then adolescent, between 12 to 19, we can use the 10 or 12. Okay, so what are the procedures to inserting this tube is, first, we should always monitor the vital signs and ensure that there is adequate oxygenation and ventilation. Next, we should measure the tube to ensure how much length we should put into the child. And then we also should ensure to wash our hands and wear gloves. And then next, we should ensure that the child is in supine position. So if it's an infant, we should wrap the infant in a blanket sheet so the hands won't be moving or be pulling out the tube. And then for older children, try to put them in upright position. Okay, so more detail about the steps. So from measuring, so we should measure from the tip of the nose here to the and then for OGP, we should measure it from the center of the lips, and then measure it to the end of the earlobe here. Okay, after the end of the earlobe, you pull it down and then to the center between the xiphoid and the umbilicus. So basically between the chest bone and the belly button, and find the midpoint, and then mark that point with any marker or a small piece of tape, so you know what length needs to be put and when you need to end when putting in the tube. Okay, so first of all, for inserting the tube, first, okay, so you're already wearing the gloves and all. You must ensure that the tube is lubricated. So you can use the water-soluble lubricant, or you can even use just the water. So for nasal, how you insert it is you put it into the chosen nostril, and then you aim towards the middle. So any to the posterior and parallel, to the nasal septum. And then when the tube touches the pharynx, you flex the child's head forward and ask the child to swallow. Then you try to advance it forward. And if the child is cooperative, you can ask the child to swallow. And infants can sometimes be even offered with pacifier. As I say, it's optional to induce swallowing. Okay, next for oral. So from the center of the lips, you position it the tube downward and insert it into the oral cavity and over the tongue. So you try to aim the tube back, down, and towards the pharynx. So when the tube touches the pharynx, you try to flex the head forward. And then if the child is cooperative, ask the child to take sips of water using the straw to while the tube is advanced, so we can increase the tube going down. So while swallowing. Okay. Next, after insertion, you should stabilize the tube by taping it securely to the face. So we can use the tape. We can use the skin tape just now, and we should also avoid the tape directly on the nair here, because as we know, sometimes future infants have very sensitive skin, so we should be extra careful. And we must also ensure that the mark that we did when measuring can be visible at the exit of the mouth or the neck, because we can aid relief and also maintain skin integrity, and also helps us check if we've inserted right or not at the correct amount. Okay, so this is a video that shows how to do it. Small.
Once the child is secure, put the tip of the tube in the nostril. Angle it toward the center of the nose. Gently push the tube down the nostril until you reach the mark on the tube that you made when you measure how long the tube should be in the correct spot in the stomach. If you feel a blockage, pull back a little bit and try again to reinsert the tube. The child can cry or beg, but if they cough, choke, or have trouble breathing, pull the tube back. Retry once the child's calmed down a bit. This is also where you will want to blow in the face of a child or smaller baby to get that startle reflex and swallow. Remove the guide wire if one was used, and attempt to aspirate fluid from the NG tube for pH measurement. Aspiration of gastric contents will allow the guide wire to be removed more easily. Take the tube to the cheek and as close to the nose as possible. The tube should not press on the nair, the opening to the nose, or it might cause pressure ulcer. Make sure you can see the mark or the number so that you can tell if the tube has moved or not.
Okay, can everyone hear the video just now?
Once the child is
Okay. So next, I'll be talking about the insertion rates, because in LGP itself, there's almost 43.5% of misplacement that can occur in pediatric patients. So what are some of it? So some of the risks. So we can have an increased risk of esophageal reflux or even and or pulmonary aspiration. We can have pneumonitis from gastric fleas that are deposited into the lungs. We can also have intracranial insertion if the infant has any facial trauma. And we can also have aspiration associated with the tube disgorgement. And then we can have trauma to the surrounding tissue. We can have pneumothorax, and we can even have the spontaneous passage through the pylorus. For example, if we inserted it too much, so it can cause feeding intolerance, abdominal pain, absorption of medications via the tube, and diarrhea, and even a severe complication. Sometimes we can have pneumonia, pneumothorax, respiratory failure, and even death. Okay. And we also have risk actually to damage the skin, the patient's skin face of the skin. And next, so that's why it's important to verify our tube placement. So basically, initial and ongoing verification is very important. So first, we should also always verify the external tube length. So you remember how we did the mark before? So we must ensure that we always see that mark. So for example, if we can't see that mark, or that mark is far away from the nose, we should pull back the tube, just pull it out and try to put it in again. And then next, we should always monitor the clinical conditions of the patient. So for example, they are showing respiratory distress cyanosis, so we should immediately pull out the tube and then put it in again. Because sometimes that could be a sign of the misplacement. For example, it could be in the trachea and such. And then next, we should always check the pH measurement. So since if the pH is 5 or below, that's the correct tube placement, as we know that the stomach is very acidic. So if it's 5 and below, then it's right that we are in the stomach. However, if it's 6 or above, we should stop because it may be in the intestine or esophagus. Because yeah, esophagus. But however, we should always be aware that some medications, such as proton pump inhibitors or H2 receptor blocking agents, can elevate the gastric pH readings. So it won't be as acidic. And also, lastly, chest X-ray is only in high risk patients required. So, for example, in the neurologically impaired or reduced gut reflux. So we don't really use chest X-ray that much. Okay, next is how to remove the tubes. So first, we should turn off the suction or the continuous feeding if applicable, and we should position the child in supine position again, elevate the head of the bed, and if it's difficult and indicated, we can ask for a second person's help to keep the child immobile during the procedure, because it is very painful for these children and sometimes they won't stop moving, so it'd be hard if we do it alone. Or if we can also ask the parental presence for support. And then next, we gently remove the tape from the face. So we can use any adhesive remover or saline wipe. And then we should occlude the tube by pinching it close and then bending it so to prevent any of the solution coming out from the stomach and such. And then hold it with the thumb and index finger, and then pull out the tube in a swift and consistent motion. So as we've seen before how it's done on a dummy, now we can see how it's done in real life.
Mom, can you hold his hand to the breastbone? There we go. Okay. All right.
So as you can see, they're giving the pacifier to the child. And they've already put the skin tape there. And now they're wrapping it in the blanket so the child can stop moving a bit.
Mama, can you hold his hands? Stay right there. Just like that. That's perfect. Here we go. Okay. Can you hold on to the tape for me?
As you can see, she's giving the pacifier again.
You're all done. You just need to put some tape on there. Pacifier tape too. Oh no! Sorry, I thought you were. Yes, you put tape on. We're gonna have to check the fluid in the stomach again.
Okay, now she's checking the pH.
Okay. Okay. Let me check the pH on this and see what we get here. Okay, we have a pH that is acidic.
And okay, as you can see, that's an example of real life patient inserting the nasogastric tube. And these are all my resources. And that's all from me. Is there any question?
Alright, question? Tak ada. Kalau apa procedures ni Pak, you all kena present semua, so saya pun tak tanya lagi satu-satu lah. Okay ya. So the concept tadi yang oral and naso ya, in neonates and infant, preferably oral kan, because it is nose or nasal breathing. Yeah. But another more another logic reason is actually the physiologic GI tract is from the mouth, yeah, not from the nose, yeah. So the more physiologic will be orogastric tube, yeah, not nasogastric. The nose is organ of respiration, yeah. But the problem if we do orogastric tube in older children and adult, because they have teeth, they have better swallowing and what we call it, chewing activity, so will be more difficult if we use OGT, ya. So maybe akan gigit-gigit dan rosak pula kan kalau gigit dengan gigi. Mereka akan punya chewing and maybe will give some problems. So that's why in older children and adult we use NGT, yeah. But actually the most physiologic should be orogastric, yeah, which is preferably in neonates and infant. Okay, so and then there are some complication. Hopefully no lah, because so far I on my experience never get such complication lah, hopefully, ya. For the evaluation, memanglah the most ideal tadi yang gastric pH tadi, tapi usually we don't have lah the tools, so in our routine practice, usually we perform one X-ray je lah. Even high risk for the radiation, because if it is only one single shot, should be okay. The radiation effect though, if collective kan, if cumulative effect, ya. So and the more affected for the radiation to the people who works in radiology lah. Not the patient or the patient that only have get some one or few shots of X-ray. Alright. And then another one usually because OGT tu we usually insert with others lah. For example ETT, and then usually in neonates tu yang kerap tu umbilical artery or vein catheter. Sekali lah we insert few equipments, and then we perform one X-ray lah to evaluate all. Okay. For the removing is simple, just remove out je lah, tak ada apa-apa. Alright. Size ada tu tak? Size tu?
Ada.
Okay. Alright. So using French unitnya bukan consensus lah. French 6 for neonates, and then usually 8 for the infant and toddler, and then for older children yang 10 or 12. and adult ya. Okay, apa lagi? I think that's all lah. Oh yeah, the apa? Actually, the more common complications lah. Kalau apa, you don't measure well ya. Oh ya, jangan lupa ya, before we insert should be measured well. There is some formula, but usually more apa namanya, more practice or more practical if we just direct measure before macam tadi kan yang di video tadi. Before we insert, just direct measurement from the mouth or nose to the ear, and then from to the xiphoid process. Kalau tak measure well, usually dia we tend to insert too long, and then so go to the duodenum. So pas di pyloric apa namanya valve tu, so, pergi ke duodenum. Or at least kalau tak pergi duodenum, dia akan apa namanya berpusing-pusing in gaster ya. Nanti masa X-ray nampak lah kan. So usually we pull out lah how many cm, we pull out, we measure after X-ray tu. Okay. Oh yeah, before after inserting pun, before perform X-ray, usually kan we just simply apa namanya give bolus of free air tu, then we check the sound in the gaster ya, on the gaster akan terdengar lah suara tu. Okay, alright. Okay, thanks.
Okay.
Right.
Thank you, Doctor.
Welcome. Next.
Me, Doctor. Can you hear me?
Yes. Yes, I can hear you.
Hello. Shit. Okay. I want to check first on my connection because it's become quite unstable for these past weeks.
Okay.
Can I off my camera?
Rahimi ke Jamil panggil? Bisa panggil siapa?
Rahimi.
Okay, alright. Oh, Jamil nama ayah. Okay, alright, proceed.
Nama ayah.
Share screen boleh? Ke maybe somebody help Rahimi lah apa? You can email your slide to Jasko. Untuk share screen tak boleh? Kalau tak boleh, tak keluar your...
Tekan present now.
Ada.
Yang dekat bawah tu. Hujung belah kanan.
Tak macam tak boleh. Saya ada suruh Zulfahan. Zulfahan. Yes.
Dia nampak lah.
Boleh Zulfahan
Saya suruh orang
screen.
lain present screen saya boleh tak?
Okay, Rahimi, you may start.
Okay, sorry for the delay. My name is Aiman Rahimi bin Jamil, and I will be presenting about the cardiopulmonary resuscitation, also known as CPR. Next. For introduction, so what is CPR? CPR is an emergency life-saving procedure which to support and maintain the breathing and circulation in the patient who has stopped breathing, also known as respiratory arrest, or whose heart has stopped, or also known as cardiac arrest. So CPR it is a combination of rescue breathing, which is a mouth-to-mouth resuscitation, and chest compression. So the purpose of CPR is to restore and maintain the breathing and circulation, which to provide oxygen and blood flow to the heart, brain, and other vital organs. The majority of cases of pediatric with cardiorespiratory arrest are mainly caused by respiratory insufficiency or respiratory arrest. Next, the next. Zul next. Dah. Hello. Okay. Uh, in the basic life saving of pediatric, this is a chain of survival where an early recognition of cardiac arrest or respiratory arrest Hello, can you hear me? Okay, for the chain of survival, first it is the early recognition of cardiac arrest or respiratory arrest. And early recognition can help the survival of the child or an adult and increase and is moving on to the early CPR, chest compression, and early defibrillation and early survival. Next. Next is the what is the importance of adequate chest recoil? Chest recoil is which when we compress the chest and we remove the compression and let the chest recoil back to its position. So the effective of chest compression uh, can push blood out of the heart chamber and thus maintain the blood flow and oxygen delivery to heart and other organ. The contraction of the heart is which is coordinated by its conductive system, which means if the conductive system is below than low or too high, the heart can function normally. So this is the reason why the recommended rate of chest compression is 100 122 per minute. And a full chest recoil is important, which is to educate perfusion to the heart muscle and blood filling of the heart chambers during relaxation, which means during the diastole phase. During diastole phase, which is the artery of the heart, the coronary artery, uh, it will supply blood to the heart itself. So therefore, it is very important for an adequate chest recoil. So to do CPR, there is a step before we can do CPR. It means that we cannot do CPR without tak boleh buat sambil lewa, macam tak boleh buat sesuka hati. There is a step before we can do it. Next slide, Zul. Here. There is a step such as a danger, responsiveness, shout for help, airway, breathing, and circulation. In circulation is where we do the CPR, and lastly defibrillation. Next, we will go by one by one. So first, danger. For danger, we must ensure the safety of the patient itself and ourselves. It means that ensure there is no harmful materials or other things that will harm the patient and us. So next is responsiveness. We must check the responsiveness of the patient by asking the child or stimulate or ask out loudly, "Are you alright?" or tapping the feet of the patient. If the patient respond, if the child respond, it will by answering or moving. So we will let the child in the initial position and ask for help. And if he does not respond, we then move to the next step, which is shout for help. Next. So for shout of help, we must get help as quickly as possible. If there is more than one person in the more than one person healthcare provider, one will do resuscitation while one will go to find assistant. If only one healthcare provider is present, we must do resuscitation first for about 1 minute before going to find assistant. So if we are in the hospital setting, we can say loudly emergency, also bring the resuscitation trolley and defibrillator. And next, airway. After asking for help, we must open the airway by the head chin tilt maneuver, where we put our hand at the head of the patient and one hand at the dagu patient, and we push it slowly upward. And then for breathing, we checking for the breathing of the patient should not take more than second, because it's by so what we should check is we check for any chest movement, any breath sound from the patient nose or mouth, and check for air movement by on your cheek. So if breathing is not normal or absent, we must give 5 initial rescue breaths and the 1 second for each breath. When giving the rescue breath, we must check the chest of the patient if it is inflated or not. And next is circulation and chest compression. Also, we must check not more than 10 seconds for the pulse, for the any sign of life and pulse palpation. So, what is sign of life, such as any spontaneous movement, coughing, and normal breathing? So, and where to check for pulse? In infant, we usually check for impulse in the brachial pulse, and for child, we usually check for in the carotid pulse. And femoral pulse, we can check for both child and infant. And if the pulse is 60 less than 60 per minute, or there are signs of poor perfusion or no sign of life, then we must quickly start chest compression. And for chest compression, how we must do chest compression. So first, we must take care is we must push hard and push fast. And when doing the chest compression, before moving on the next compression, we must allow a complete recoil of the chest, because we want to allow the coronary heart to supply blood to heart itself. So what is the techniques? For first, in infant, for if there is one rescuer, we can use two fingers, tips of fingers, to do a compression. If there is two rescuer, we can do two thumb chest compression technique. Uh, there's a video later and picture that I will show you. And if for a child young, more than 1 year old, we must use heel of one hand over the lower sternum. And for more larger child, we can use two hands with finger interlock. And which for the side of compression, we must compress at the lower half of the sternum. And what about the depth of the compression? And for infant, at least one third of the depth of the chest, or for about 4 centimeter. And for child, uh, for about 5 centimeter. And for the rate of the compression, we must push at the rate of at least 100 to 120 millimeter per second. And for the ratio of compression to breathe, we must do 30 compression and 2 ventilation. This means that at 30 compression, one one breathing. This ada salah sini. Maksudnya, after doing 30 compression, we we give one rescue breathing. There's a video later. Okay, next. Boleh main tak Zul? This is for infant. This is a two finger technique. And next, this is video for a child. older than 1 year old. Hello. Okay. For the ratio of compression to breath, it is correct. 30 compression and 2 rescue breath. And this is next is the picture. For the first picture is the tip two finger technique, and below it is the two thumbs uh, compression technique, where if there is two healthcare provider present at the site of scene, and the upper right is the one heel hand compression technique, which we have seen in the previous video, and this is the two hand interlock chest compression technique. Next, so we must do not stop chest compression. Continue doing the cycle of CPR, and you do not stop it until one of these situations happen. First, if the child shows any sign of life, such as starts to wake up or move, or the child open his eyes or breathe normally. Or if the another healthcare provider arrive to assist or take over. And next is if the healthcare provider is exhausted, because if the healthcare provider exhausted and still want to do the chest compression, it may cause harm to the infant, because the chest compression may become incorrect and cause damage to the organ in the chest. And next is after doing the chest compression, next slide is the defibrillation. Uh, Early defibrillation is also one of the key in the chain of the survival. First, before doing defibrillation, we must assess the patient if it is needed for shock, and if after that, we can attach AED. AED is automated annual defibrillation or manual defibrillator. When attaching the defibrillator to the patient, we must do not interrupt the chest compression, which means that one person will doing the CPR and one person will attach the defibrillation. And after that, if we are using the automatic one, we can just follow the voice prompt. And after the shock was done, we must do CPR immediately. And and lastly, if the patient show any sign of life, we can apply recovery patient. Recovery patient is applied when the victim resume normal bleeding or remain unresponsive. So, thing to take note is the recovery position must be stable, near a true lateral position with the head dependent, and there is no pressure on the chest that could impair the breathing. I think that's all from me. Thank you.
Alright, yeah. Any questions?
Doctor, I want to ask
Yes.
question.
Good, Ilham. Yes.
Okay. During my high school, I have been through CPR session. No, CPR seminar before, and it stated that mouth-to-mouth resuscitation is no longer practiced today. Is it true?
Yes, because direct mouth to mouth, because the risk of infection transmission, anything especially macam hepatitis, HIV, and so on and so forth. But actually kalau in community punya CPR, nowadays they provide macam one piece of macam bukan blanket macam cadar lah, apa nama sebenarnya saya pun lupa macam one filter lah, one piece of filter which is actually available to buy lah. Saya pun tak ada lah. Usually ED people dia selalu always keep on their pocket lah this filter in case they need to do mouth to mouth breathing in community. The second thing, kalau in hospital setting we always know never do the mouth to mouth because we use the back valve mask tu. Ada tak yang back valve mask? Coba tengok yang yang breathing punya ini proses. Atau kalau yang more ideal yang itu, yang kiri bawah tu. Pakai yang itu. And then furthermore, kalau not effective, we intubate the patient. Kalau intubate, the tube will enter the trachea kan, turun di laring, so will direct ventilation. So itulah. Saya tak pernah prepare because yang filter ni, because usually I work in a hospital setting kan. Ada sentiasa ada big valve mask, ada ETT, we can intubate the patient. Kalau let's say we need to do CPR in community setting, I have one experience lah, maybe 2 or 3 years back, just on the roadside, one guy collapse, so I just do chest compression for the breathing. We just try to what we call it make arm movement. So if we lift the arm of the patient, hopefully there will be some increase of intrathoracic. So bukan increase, akan negative pressure of the intrathoracic pressure tu. There will be some air entry lah. Tapi it is not effective actually. Memang the most effective memang kena ada positive pressure ya. Positive pressure maknanya we kena blow the air to the lung. Sebenarnya kalau in community memang sometimes you need to do mouth to mouth, tapi lah yang kalau you don't have the filter, better don't do. Okay. Kita ada. Okay, I'm clear. Okay.
Clear, Doctor.
Any other question? Okay, yeah. So just brief summary. Nanti later you will practice in year 5 ya. Yang for neonatal and infant CPR, we call it neonatal resuscitation program lah, NRP kalau in apa American punya style, American AAP guideline. Kalau UK guideline kita sebut NLS ya, neonatal life support. So malah 1 2 3 lah, one breath and 3 chest compression. Nanti in year 5 you will have 2 day session lah untuk to practice, to have detail and practice to do neonatal resuscitation. At least for now you know the knowledge, yeah, you have some knowledge about that. And then for the older children and adult, similar tadi ya, 30 to 2. Actually you will start from BLS lah, basic life support. Nanti year 4 masa you posting NS tu, you will get it ya. And then ada posting ED, saya rasa year 4 ke year 5 ya? Year 4 ya. Posting emergency nanti you minta juga nanti ya. For practical session. Okay. For details memang itulah nanti kalau nak saya explain detail nanti tak cukup lah. Usually the apa namanya proper neonatal resus punya course tu dia at least 2 days. Ada yang 3 days hari itu. 2 to 3 days course. Ada lagi yang pediatric sih, yang older children ada advanced pediatric life support. So memang so many things to practice lah. So that's why at least you have some knowledge about that. You may review the video and slide tu, nanti you belajar sikit-sikit ya, supaya masa datang ke course ke apa-apa, you have dah ada idea. Other than kalau you go to course tu without any knowledge dan tak tahu apa-apa, susah. 2 hari course pun tak akan boleh buat. Okay, alright. Thanks. Next. Who's next?
I'll share the screen.
Shamini ni. Alright.
Okay, so can you see my slide?
Not yet. Okay.
Bismillahirrahmanirrahim. My name is Shamimi and I'm going to share about the endotracheal intubation in pediatrics. So this is my contents. Okay, so what is intubation? Basically, it's a process of inserting tube, which we call endotracheal tube, ETT, through mouth or nasal, usually through mouth, and then to trachea for airway management. So these are the indications for intubation. So basically, the first one is if the back and mask ventilation or continuous positive airway pressure is insufficient. Second one is if the patient is using direct suctioning of trachea. The third one is the patient if we want to maintain or protect the airway, and the last one if the patient has diaphragmatic hernia in newborn. Okay, what is the contraindications for intubation? the only one of contraindication intubation is if the operator or the one who wants to perform it is inexperienced in intubation. So the person need to use back and mask ventilation until there is more expert person. But back and mask ventilation is actually contraindicated in diaphragmatic hernia patient because it will increase because the stomach and intestines become distended with air. So if we use back and mask ventilation, it will further impair the lung function. So if the patient has diaphragmatic hernia, we need to quickly find a person who can intubate the patient. Okay, the next one is the equipment. The first one, what you need is a bag and mask. This is bag and mask with high oxygen flow. Second one is laryngoscope. And the blades. The blades we have two different types, which is the mag. This is the mag, and the Miller. The Miller is the straight one. So usually we use the Miller for infants or neonates, and the mag for more older children. And the size depends on the child. So for neonates, we use a 0 or 00 size. For infants, we use 1. Or sometimes 0, depends on the size of the patient. And this for children we use the size 2. And then endotracheal tube. This is also depends on the patient's age and also patient's age. If the patient is below 1 years old, so the size of tube is according to their weight. But if the patient is more than 1 years old, you need to calculate the patient's age, the patient's age for the exact size of the tube. Next one is pulse oximeter and ECG monitoring. This is for to monitor the patient's condition throughout the procedure. Next one is suction catheter and device, scissors and adhesive tape, stylet, optional. This is optional and usually not used. And then the sedation, such as midazolam and morphine, or muscle relaxants such as rocuronium and succinylcholine. Okay, the next one is the preparation before we do procedures of intubation. We need to inform and to get consent immediately if for the patient. One of other doctors can explain the technique, complication, and benefits of the procedure, and then prepare the equipment, monitor the patient's heart rate, respiratory rate, blood pressure, and oxygen saturation throughout the procedure. Positioning the patient, where we use a sniffing position, I will show later. And then we do a ventilation technique first, which is where we continue back and mask ventilation for 3 minutes if it is necessary. But if the patient is in cardiac, if the patient is in cardiac arrest, this will need to disregard. And then the last one is sedation and neuromuscular blockade. Depends if the patients need it. If the patient is yes, if the patient need it. Okay, this is the sniffing position. You can see this one is for infant. This one is for toddler. You can see the glabella, which is the side of between between the eyebrows. Okay, between the eyebrows. So it need to be horizontally aligned. The neck need to be wide open. And also, you can see the external auditory meatus is horizontally aligned with supranatal notch peak. This is for the toddler sniffing position. And this one is for older children sniffing position, where we need to focus on the anterior neck space where it is wide open. Okay, the procedures. The first one, need to tilt the patient's head back while lifting the chin. Open patient's mouth by pushing lower jaw with thumb and also pushing upper jaw with index finger like this. Okay, and then you insert the laryngoscope from left side of patient's mouth because you want to move patient's tongue and to detect the epiglottis. These are the examples of epiglottis in newborn, child, and adult. Okay, so the difference between Mac and Miller blades just now, if you use the curve one, which is the Mac, insert the blade between the tongue and vallicula. And if you use the straight Miller blade, insert the blade on top of epiglottis like this. This is epiglottis, so on top of it. Okay, the second one is when you have detect the epiglottis, you need to pull the laryngoscope upward, forward and upward like this, not backward because this will injure the patient's teeth. And then this is to view the trachea and the vocal cord, so you can see it clearly. So when you've detect the trachea, insert the lubricant endotracheal tube via right side of the mouth, so as not to obstruct viewing area, because we put the laryngoscope at the left side. And also, okay, the tube should be inserted approximately 2 cm past the vocal cords. This vocal cord, 2 cm, roughly at level of thyroid gland. So this is the thyroid gland. Okay, this is important if you want to intubate the patient. If the intubation is not done within 20 seconds, you can, which means you cannot insert the ETT. So the attempt should be aborted, and your reventilation using the back end mask need to be continued. And you need to find other person who is more experienced and expert in this. Okay, the fourth one is while holding the endotracheal tube in place, you can remove the laryngoscope. If you use the stylet, this is where you remove the stylets from inside the endotracheal tube. And last one, attach the end-tidal carbon dioxide detector and MU bag to endotracheal tube. This is the MU bag or back end mask. Squeeze the bag at regular intervals to begin ventilation. So if the detector turns gold, this is for the carbon dioxide detector. The tube is ventilating the lungs. So checks for bilateral lung inflation. Finally, secure endotracheal tube with tape and attach the ventilator to MU bag. And you can also need to insert orogastric tube to decompress the stomach and check the chest radiograph. Check by using chest radiograph. This is the videos. I think it sometimes.
Can you hear the sound?
Yes, we can. Nini, we can't hear the sound now.
Oh yeah. Oh. still can hear the sound?
No. Try kuatkan volume.
I think there's a lagging in internet.
Syamimi bagi link kat chat bagi saya share.
I think it's okay lah, because the text is quite clear kan. No,
Oh,
no
okay.
apa, no sound pun, no apa explanation pun tak apa. Boleh baca je kat situ.
Oh, okay. Oh, internet
It's
lagging.
okay. Dah, anything else? Dah habis your presentation.
Last one is the conclusion. Can you see the slides back?
Yes. Wait, it's loading. Now we can see.
Mana Syamimi tadi?
Dia ada internet connection rasanya. Dia terkeluar tadi.
Hilang terus. Another two kan ya? Yang belum.
Doktor.
Siapa? Yang belum? Oh, ni Syamimi dulu. Alright, Syamimi.
We can't hear you, Syamimi. Kita tak dengar. Now boleh.
Okay, can you hear me? Okay. So you haven't my presentation about application.
Tak dengar.
Complication. Sempat tak complication tadi?
Tak.
Tak. Okay. It's just a short one. Can you see the slides?
No.
Not yet.
Okay. Maybe it takes time to share. Now can you see it? I've already shared actually.
Yes, we can see now.
Okay, so these are the complications. I'm sorry, my internet is so poor. Okay, these are the complications for endotracheal intubation. So the first one is esophageal intubation, where you mistakenly intubate the patient into the esophageal, and the tube can be in situ and dislodged. The second one is right lung intubation, where it can cause high peak respiratory ventilation. Next one is trauma to the upper airway. If you do the intubation procedure the wrong way. Okay. Next one is a pneumothorax. And last one is subglottis stenosis, but it is actually a rare and late complication. So that's all.
Alright, questions? Okay, edit ini quite apa namanya advance ya. So usually masalah nanti bikin masalah natal recitation program tu practice. Maybe you can try to the mannequin, but rarely we will give you opportunity lah to the babies. Usually even houseman pun tak selalu boleh buat, tapi once you get NRP certificate tu, so you must be able to do you must be able to perform. So tapi biasa je banyak houseman yang tak boleh, and then refer MOM, even MIMO pun tak semua boleh buat. Few times I need to help them lah. Okay, so common first the size of laryngoscope tadi yang the type tadi yang Miller, the straight one for neonates and infant ya. Yang Mac for older children. Karena kalau yang older children pakai yang Miller yang straight, nanti dia pasti risk of teeth punya fracture lagi tinggi, so kena bengkok sikit. So yang the straight one is much easier to see the epiglottis ya. Epiglottis. Tapi kalau yang budak besar nanti gigi dia patah pula. Right, and then sizing tadi ada yang laryngoscope yang 0 is for preterm ya, 0 yang very preterm yang below 1 kg. Kalau term baby infant tu pakai size 1 lah dah. Dan older children tu tengoklah size tu ya, tengok the size of child. Toddler maybe 2, tapi kalau dah child school age maybe size 4 or 5 lah. The blade tu. And then the ETT size juga tengok the size of the larynx and trachea of the patient. Tadi tak yang term baby 3.5, kalau preterm maybe 3 or 2.5 ya. The smallest is 2.5 ya. And then infant maybe 4, up to 1 year old ya. And then tiap tambah setahun tambah one size ya. 2 years maybe 5, 3 years maybe 6. and so on and so forth. Okay, and then communication tadi ya, yang common one of course kalau teknik bukan teknik tak betul yang most common problem dia tak masuk ya, kan fail to enter the larynx and trachea ya akan masuk esophagus because the easier one kan, esophagus is no valve, no epiglottis. So kalau dia tak masuk betul ke larynx, akan masuk ke esophagus ya, kat bawah dia. And then if too deep, another one is to see the how deep you insert ya. Sama dia macam you masukkan NGT tadi, size from the mouth to the ear, how many cm. If too deep, dia akan masuk to the usually right bronchus ya. Karena the position of the bronchus yang right dia akan quite vertical, yang left bronchus will be horizontal ya. So akan susah masuk ke kiri, so usually akan masuk kanan. So that's why compare lah. You can see the chest movement. So sama ke tak, chest rise tu similar atau, and then you can auscultate sama ke tak. Kalau louder on the right, you need to pull out. And then after insert pun nanti buat X-ray kan, tengok how deep, on which level of the vertebra. Usually the larynx is on the thoracal 1 kan, or maybe cervical 7. You just masuk in level of vertebra thoracal 2 or 3 is adequate. Thoracal 4 already ke rhina ya. Udah thoracal 4 tu dah tend to go to right bronchus. So itu je lah. So the video you can review, nanti boleh praktis masa year 5 tu mannequin ya. Okay, any more question? Tak ada? Alright, thank you. Next one, 2 lagi kan ya?
2 lagi Doktor.
Zulfarhan ni. Alright.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. For today, I will present about a peak flow meter. And this is the list of contents. And what is a peak flow meter? A peak flow meter is a device which records the peak or maximum flow during a forced expiratory maneuver, where PEFR stand for peak expiratory flow rate, and the unit of for the peak flow meter is a liter per minute. And to take note that the peak flow meter only can record the flow of the lung, where there is other lung function test, which is a spironometer, which can record flow in and out of the lung and the volume of the lung, where the peak flow meter cannot record the volume of the lung. And what is the uses of the peak flow meter? Peak flow meter can be used as a diagnostic tools. But that is a tool, but it's just a confirmatory tool because this is like asthma. The asthma itself, it can be diagnosed from the clinical history and clinical examination. And if the clinical setting, if the clinical setting or hospital have the spirometer, it's better to use the spirometer than the peak flow meter. But if the clinical setting just have only have peak flow meter, it's usually enough for confirmatory diagnosis, especially in asthma or chronic obstructive pulmonary disease. And it's used also for the monitoring the progression of asthma, where the asthma patient have a like a diary, like a record that where they use the peak flow meter and record it in in the book, so that when they meet the physician can what we call can monitor or interpret the reading and can adjust the medication according to the what level of the asthma itself, which I will present later. Biflometer is indicates to asthma patient and COPD patient. And how to use biflometer? Tadi ada gambar. The biflometer that is like what we call like a read. This the read of the peak flow meter first. We must make it to the zero, kita tarik ke sampai ke hujung to the zero reading and use the peak flow meter while standing up straight. It's better to standing. Sitting also we can do when sitting, but it's better to do use peak flow meter while standing up straight and take in as deep a breath as possible, and then place the peak flow meter in the mouth with the tongue under the mouthpiece. Because we don't want the tongue halang disturb the flow the airflow from the lung, and close the lips tightly around the mouthpiece and blow out as hard and fast as possible, and do not throw the head forward while blowing out. It means that when we want to blow out make sure that the head is as much as can do not stand still. When we blow out, do not ke depan macam tu. And then breathe, and then also take note that when the patient will blow out, dia terbatuk ke apa, advise him to repeat it again, because the cough also can affect the reading of the peak flow meter. And after that, breathe a few normal breaths and then repeat the process 2 times, and write down the highest number of 10 and do not average the numbers. Is the video. Yeah, I will show a video about the flow meter.
peak flow meter measures how fast and hard you can blow the air out of your lungs. Before each use, make sure the sliding marker is at the bottom of the number scale. Stand or sit up straight with your chin slightly lifted and look straight ahead. Keep this position for the entire time. Blow out and empty your lungs as much as possible. Breathe in deeply to completely fill your lungs with air. Put the mouthpiece between your teeth and close your lips tightly. Do not put your tongue on the mouthpiece. Blow out as hard and fast as you can through the mouthpiece. The sliding marker will move up the scale. Look at the number on the meter to see where the marker stopped. Repeat the steps and measure your peak flow 3 times. Record the highest number you reached. Be sure to reset the meter to 0 before each time that you blow into the meter. Keep a record of your peak flow number around the same time each day for 2 weeks while you are feeling well. The highest number is called your personal best peak flow. Your asthma action plan will use your peak flow numbers and treat your based on your symptoms and
Tindas sekejap.
Okay, Zul Farhan.
Ya. Nak share semua balik. Okay, there is other video for. Okay, next is how to record the peak flow measurement. First of all, we must establish baseline measurement for the normal population. That is like a baseline or normal reading for the population, which means the reading itself, the peak flow reading itself is affected by age, height and gender. But
So Farhan, we can't see your slide.
tak nampak lagi. Kejap. Nampak tak?
Belum lagi.
Kita share. Nampak?
Tak nampak slide lagi. Nampak presentation nama je.
Nampak lagi ya? Slide.
Tak.
Kejap. Masalah tu.
Sekarang nampak mute.
Nampak Dah nampak lah.
Nampak dah.
Okay, how to record the peak flow measurement. First of all, we must establishing a baseline measurement for the like normal population. There is a normal peak flow reading like in the population, just like blood just like blood pressure, just like blood pressure or blood sugar or something like that. Nanti after that I'll show. But for the when monitoring the for asthma patient, they must do the self monitoring. The normal reading for the population is not what we call is not reliable for the patient, because for asthma patient the best reading is usually different from another person. So we must determine the normal peak flow measurement where for the asthma patient, where the patient should measure the peak flow during no asthma symptom or after they take the medication. After about 15 to 30 minutes, they must take the what we call the peak flow measurement. And just like how to use just like procedure, perform 3 measurement with the same peak flow meter 2 to 4 times daily for 2 to 3 weeks interval. and then notes the highest speed flow measurement achieved, which the highest speed flow is indicated as the personal best, best, so that we can compare with other measurement where the number is used to determine for future peak flow measurement, and number range or the good where what we call the goods reading is about 18% to 100% of personal best peak flow measurement. And then there is a like a zones where indicate where the reading of the peak flow meter that the patient take, where the green zones is the peak flow measurement is above 80% of the personal best, and the yellow zone is the peak flow between the 15% to 80% of the personal best, and red the peak flow measurement is below 50% of the personal best. The zone is useful for the physician that handle the asthma patient, so that they can can plan a proper management for the patient if the patient in this zone. And this is a normal peak flow management according to age, gender and height. And then this is a asthma diary. Same also. And this is a asthma action plans. And for peak flow meter, the complication there is no known complication, but make sure that the peak flow meter in good condition. At least what you call clean the peak flow meter dalam 16 kali for to ensure that the peak flow meter can do the work properly. I think this is my references. I think that's all for me.
Okay. Any questions? Tak ada ya? Simple ya. Actually, what is the prerequisite to do peak flow meter, Zul?
What doctor?
Apa syarat dia? Syarat untuk buat peak flow meter apa? For the patient.
Syarat dia.
Must be? The child must be?
Child must be 5 years older or
Actually, the age to relative. The absolute thing is must be cooperative.
Cooperative.
You must be able to follow the instruction and then able to blow as strong as possible. Yeah? So it is forced expiratory volume, FEV1. So the age tengoklah, sometimes umur 7 pun tak boleh lagi. School, kalau school age should be okay because budak datang ke sekolah kan dia pasti boleh follow instruction. 5 and 6 tengoklah situation, ada yang boleh ada yang tak boleh ya. And then it is gold standard for diagnosis of asthma ya, because asthma is non condition of bronchoconstriction ya. Wheezing, ronca itu justru dia bronchoconstriction, sempuk patient. So dia akan reduce the FEV1 tu, and then will have good response to bronchodilator. After naps atau after giving MDI, dia akan terus improve by at least 15% ya, 15. So, kalau for example masa dia sempuk, masa yellow zone tu yang For example 60%. Kalau yang dah red zone dah below 50%, dia usually severe attack tu tak payah lagi buat picrometer, better we research the patient. Still yellow 70%, okay lah buat FEV1, okay 60, and then after that dia akan improve maybe 80, maybe 90 ya. Okay. Percent from the ideal kan of the patient, but let's say the patient doesn't have any baseline punya data, you just check the FEV1 volume berapa. For example masa during wheezing attack dia volume dia 200, and then after naps or after MDI dia increase to 250, so okay lah tu. So it is proven bronchoconstriction that respond to bronchodilator. So kita diagnose patient as asthma lah, acute exacerbation of bronchial asthma, dia kena asthma attack. So that's why kan to diagnose asthma tu no problem kalau dia 6 years and above, dah budak sekolah tu. So problem kalau below 5 ni kan still toddler, apalagi infant, we cannot get the gold standard of the diagnosis tu. Mainly we do our based on experience lah, tengok dia before naps dia rongkai, after nap terus clear lah. And then with positive asthma predictive index. Okay. So tu ya, kalau below 5 kita pakai positive asthma predictive index lah to diagnose bronchial asthma tu. Recurrent wheezing, that patient has positive asthma predictive index ya. So we can diagnose asthma ya, even patient 2 years or below ya. Jangan kata kalau below 2 years you cannot diagnose asthma, wrong ya. So we can diagnose asthma at any age actually. Tapi itulah susah nak confirm. Kalau 6 years and above you can easily confirm with spirometry to picrometer. Okay, alright. So last kali, thank you. So last kali siapa?
Idham, doktor.
Alright, listen.
Okay, can you see my slide?
Yes, we can.
Okay. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I am Muhammad Afi Idham bin Ismail, matric number 1817741. And for today's presentation, I will share and discuss with you guys about chest tube, or also known as thoracostomy tube. So this is the outline for my presentation for today. Okay. So before we go deeper into our conversation, into our discussion for today, we should know what is actually thoracostomy tube or chest tube. It is actually a procedure where tube or small catheter is placed through chest wall into pleural cavity. It is actually a common invasive procedure in adults. However, in pediatric patients, due to less number of cases that are indicated for this procedure, therefore this procedure is not that common in pediatric patient. So these are the indication for thoracostomy tube insertion. The first one is pneumothorax. It can be iatrogenic pneumothorax, spontaneous, and also traumatic pneumothorax. After that, hemothorax also is one of the indications for thoracostomy tube insertion. After that is pleurodesis, which is destruction of pleural space, and lastly is pleural effusion. So for contraindications for thoracostomy tube insertion, there are two types of contraindication. The first one is the absolute contraindication, and the next one is the relative contraindication.
absolute contraindications means that by hook or by crook, we cannot do thoracostomy tube insertion in this patient. So if the patient have transudative pleural effusions due to liver failure, then these patients are absolutely contraindicate for thoracostomy tube insertion. And for relative contraindication, it means that the patient can have thoracostomy tube insertion under several circumstances. So if the patient have conditions that increase bleeding, then this patient are relatively contraindicate for thoracostomy tube insertion. However, if it is an emergency situation, then this patient can go to thoracostomy tube insertion procedure. And the next one is skin infection. The next one is pleural adhesions. And for pleural adhesions, previous fluorosis and also pulmonary surgery, thoracostomy tube insertion can be done in this patient. However, it should be guided by ultrasounds or any other imaging modalities to avoid any complication in the future. Okay, these are the equipment for thoracostomy tube insertion: lidocaine, which is an analgesic, needles and syringes, scalpels, and the list goes on. So what are the things that we need to prepare before we do the thoracostomy tube insertion? The first thing that we need to do is we need to take complete and proper patient history, and we also need to do proper physical examination. This is to avoid any further complication that might occur. And after that, we need to ensure the surrounding area where we want to do the thoracostomy tube insertion in a sterile condition. We need full body drape. We need to wear gown, we need to wear gloves, face mask, and also eyewear. And also, if the patient present with penetrating trauma, then we need to give antibody prophylaxis to the patient first. And after that, we need to give sedation to the patient because this thoracostomy tube insertion is very painful procedure. Therefore, we need to give sedation such as lidocaine. And after that, we need to determine the site for insertion. So in normal patient, the thoracostomy tube is inserted at fourth or fifth intercostal space in the anterior axillary or mid-axillary line. However, in emergency condition or emergency situation, it is inserted at nipple line in male patient and in inframammary for female patient. And if the patient present with pneumothorax, then we should insert the thoracostomy tube at the second intercostal space at the mid-clavicular line. And the tube direction also should be determined by the clinician that want to do this procedure. So if the clinician are going to drain air, then the tube direction should be anteriorly. If the clinician want to drain fluid, then the tube direction should be posteriorly. So this is a chest tube. This is chest tube. Chest tube is actually a silicone or PVC tube with radial opaque strip and a gap. And the drainage hole, as you can see in the red circle, must be fully inserted into pleural space. The size is according to the patient height and also indication for placement. So this is the chest tube sizing. As you can see, the sizing is according to the patient weight and also the indication, the placement indication, and it is measured in French size, which is 1 French size equal to 3 millimeter in diameter. Okay, for technique, to perform this procedure, there are two techniques. The first one is the standard technique. The next one is the Sendinger technique. So I will present about standard technique first. So firstly, you need to make an incision at 1 or 2 interspace below the proposed point for thoracostomy tube insertion. After that, you need to use clamp to make a blind dissection through subcutaneous tissue. And after that, you should spread the clamp when it have reached the pleural space. And after that, you need to insert your finger to make sure that the pathway has already lead to the pleural space. After that, you need to grab the chest tube with the clamp, together with the clamp, and insert it. And after you have insert the chest tube, you need to suture and place it securely. So that's for standard technique. Now let's move into the Seldinger technique. So in Seldinger technique, you need to inject a needle. So that needle is attached with a syringe. with a saline solution. And after that, after you have insert the needle, you need to remove the syringe and you need to insert a guide wire through the needle into the pleural space. After you have insert the guide wire, you can remove the needle and you can leave the guide wire in place. After that, you should make a small incision. So make sure that the small incision does not cut the guide wire. And after you have made a small incision, you should put a dilator so that the pulse will become more dilate. And after you have put the dilator, you can remove it and then you insert the thoracostomy catheter into the pleural space over the guide wire, and you can remove the guide wire lastly and secure the thoracostomy catheter. So basically, these two techniques can be guided by ultrasounds and any other imaging modalities. These ultrasound and other imaging modalities also can minimize complication, and they can also accurately identify pneumothorax location. So to manage the catheter or the tube, if we notice that there is clot or fibrinous debris in the chest tube, then we need to inject 5 ml of saline in a sterile fashion daily to clean that clot or fibrinous debris. After that, we also need to assess the presence of air leak periodically to determine whether this tube can be removed or not. And after that, we need to take care of the tube. So we need to clean the tube with antiseptic if the closed suction system is disconnected. And we can also inject fibrinolytic agents because fibrinolytic agents may aid in maintaining flow and also restoring flow in obstructed catheters. And also we can clear the obstructions in the tube by other maneuvers if it is no longer draining. So to remove the catheter, or the chest tube, the first thing that we need to do is we need to check the criteria fulfillment. So in patient with pneumothorax, if the lung is fully expanded and there is no visible air leak, then the chest tube can be safely removed. And in patient with pleural effusion, if the lung is adequately expanded and the daily fluid output is less than 100 to 300 milliliter per day, then the chest tube can be removed. After we have checked for the criteria, we should make an adequate preparation of supplies and also equipment. After that, we should explain the technique used to remove the chest tube to the patient. This is because the removal of the chest tube is very painful. So we need to tell the patient beforehand so that the patient can prepare for it. And after that, before we remove the tube, we should remove the suture that secure the tube in place first. Only after doing that, we can remove the tube, occlude the site with dressings, and tie the suture. For the fifth step, it is advisable for at least 2 clinicians to work together at the same time. The first clinician should remove the tube and occlude the site with dressings, and the other clinician should tie the suture at the same time. And lastly, we should secure the dressing with tape and continue with chest radiograph if it is indicated. So this is the last thing in my presentation, which is the complication for thoracostomy tube. The most common complication is malposition. If we wrongly insert the thoracostomy tube or the chest tube, it will represent a form of penetrating trauma, and it will make the patient it will make the patient in a dangerous situation. Therefore, we need to carefully insert it. The next common complication is the infection. This is due to prolonged duration of the chest tube placement, and it will lead to lung empyema if it is not treated. And the next is nerve and blood vessels injury. The commonest nerve and blood vessels that may be injured after thoracostomy tube insertion is the intercostal nerve and also intercostal artery. And other surrounding organ also may be injured due to this procedure, such as heart and also lung. And the rarest complication is the re-expansion pulmonary edema. This can actually occur after we rapidly re-expand the lung that have been collapsed. Therefore, it will lead to pulmonary edema. So I think that's all from me. Thank you.
Okay, thank you, Ilham. Any questions? Tak ada? Okay, just jawabnya also quite okay, question? Yes, Shamimi?
I want to ask, there's two technique that Ilham has showed. So which one is more common, or is it depends on certain condition?
Okay, for technique, have two technique. The first is standard, and the second one is Sendinger. The standard techniques is usually used in adult patient with pneumothorax or hemothorax. However, for Seldinger, it's typically performed with the aid of imaging modality, and I don't know the which one is the commonest. However, for Sedinger technique, there is a side effect. Yeah, and there is disadvantage. The disadvantage is it is unable to access if there is any adhesions between the pleural and the lung surface.
Okay, ya. So usually saya dengar tuh ya ultrasound guided ya. So kalau patient udah well prepared, we use seldingan lah ultrasound guided. Tapi kalau for pneumothorax kan we need to do it very fast, very quick kan, to rescue the patient. Because kalau nak tunggu pergi ke radiologi pakai ultrasound guided kan nak tarik cari mesin ultrasound lambat lagi. So kalau pneumothorax we need to just prick, just tepuk je lah, just masukkan terus di needle and just tube ya. Actually kalau Seldinger tu yang for proper test tube insertion. Okay, so this one also quite advanced ya. Even saya pun jarang-jarang buat. Actually pun yang buat pun will be in OT setting kan. Kalau surgeon dia biasa buat. Kalau for emergency tu very rare. Masa in NICU usually pun yang buat pun neonatologist ya. So okay lah, as long as you know the technique. Let's say you have a case of pneumothorax ya, you need to do it in emergency. Sometimes we cannot wait kan, kalau pneumothorax memang kena buat terus ya. Kalau pasal yang lain, for example case lain like MVM we do proper lah, ultrasound guided in OT and so on and so forth. Okay, so that's good lah, semua dah itulah, because macam Idham tadi present yang quite advance, saya pun baru ada idea nanti we will divide lah macam chest tube ni baik untuk year 5 ni. Year 3 korang baik yang more basic macam OGT tadi, and then yang IV line, PLCNS yang on Tuesday tu. Chest tube maybe yang untuk yang masa NICU baik untuk yang year 5 lah, chest tube, and then urine umbilical artery or umbilical vein catheterization, outline itu untuk year 5. Baik, pasal intubation tadi baik untuk year 5 lah. Kalau CPR for you pun boleh ya. Actually intubation tu is part of the CPR resuscitation punya procedure, tapi kan ada dua ya, CPR itself and intubation is. Okay, alright. So you share dengan grup lain tak yang present? Sometimes you share juga ya, the same slide ke apa-apa, tapi coba tengoklah kalau grup lain dia ada present other topics, so you may follow juga. Itulah yang macam year 5 hari itu dia, even though grup punya discussion macam ni, so all yang posting tu dia join semua. You all tak buat appointment dengan yang grup lain ya. Saya tanya je yang grup lain bila dia nak buat kelas tu, so better you join lah. You hopefully ada even same apa namanya procedure pun maybe you can learn different thing from different angle kan. Kalau orang present yang presenter dia prepare from other source, maybe ada different teknik, different procedures, boleh. Unless kalau same slide yang you share, bosan lah dengar. Okay, alright. This is your last week kan?
Yes, ada.
Okay, so good luck ya for next week. You pergi ke IM ya? Pergi IM,
Yeah.
okay, nanti hopefully by end of December you can go back here lah. Alright. So for face to face, kalau tak boleh datang face to face, I don't know how to teach you. Even Datuk Fazil pun dah give up, dia tak nak buat long case presentation. Maybe kalau for long case presentation we can discuss few things kan. Macam last hari tu ada kan yang year 3 present kalau tak silap.
Ada doktor.
Itu lah. Tapi lah because you never go to the ward, never seen any patient, so jadi never saw any patient, jadi susah sikit. Kalau macam year 5 at least dia orang pernah tengok patient masa year 3. Atau kalau yang udah block 2, 3, 4 kan you boleh minta from the previous blocks. Kalau block 1 yang paling susah. The most tough to do is block 1 always. Buat pediatrics. Alright, okay. Let's go with our speaker for our answer. Okay, thank you all. Assalamualaikum.
Thank you, doctor. See you soon.
Thank you, Doctor.
Yeah.
Thank you, Doctor.